This is a presentation on the bedside neuro check. Bob asked me to head this up, and I felt that this would be the best way to do so. I know that this has been drilled into our heads over and over, but it is because it is an important part of what we do on a daily basis for a large portion of our patients. Over the coming weeks, Bob will probably be checking in on us during shift change and evaluating how we do these bedside neuro checks. Again, this is not because he's not confident in us or anything like that, but just wants to make sure it's being done in a consistent way, again, because it is so important to what we do. Alright, so here's some cool food for thought that Bob had mentioned to me that really kind of stuck out and resonated with me. He said, you know what, neuro is unlike any other specialty. You know, if you're taking care of a patient and they have chest pain, you know that you need to go take a peek at the patient and evaluate it. But your exam of the patient doesn't necessarily mean a whole lot, you know, because you're going to be getting an EKG and the troponins. And in neuro, you don't really have that luxury. You are your own EKG. You are your own troponins. You know, it's up to you to be someone that is able to detect these changes based on your exam of the patient. And be sure that you're the one picking them up. And you know, that really stuck out to me because it's true. It highlights why what we do is so important. So bedside neuro checks, why are they important? Well, the big ticket items in all of this are the big reasons why, to me. It gives patients and providers peace of mind knowing that they are being assessed regularly. These neurosurgeons and neurologists know that their strokes and their surgical patients are being checked on, that they're being monitored, and a baseline is being established. Which brings us to B. It allows for a given, undisturbed time to get that baseline neurological assessment done on a patient. You're doing it at shift change, you're doing it with someone else, and you're not being distracted by those people that need their PRN meds or needs to pee, who's got the beeping IV, who's hitting the call light, those kinds of things. You've got that time set aside to go to the bedside and get it done. And then C, finally, it allows for the oncoming and offgoing shift to be in agreement on a patient's neurological function. You guys are both seeing the same thing at the same time, and you guys can say, hey, at 7 a.m. or 7 p.m., this is what this patient looked like. We both agree, we both saw the same things. We can say definitively at this time, this is how this patient looked. And that's extremely important because if there's any kind of deviation from that baseline establishment at shift change, you can pinpoint exactly how far along it's been from when that patient was like they were previously. Okay, so the first thing that I look at on a neuro check is how alert is the patient? Are they awake and alert? Are they awake whenever you enter the room, or will they only wake up with a sternal rub, or what? So I thought this little chart on the left did a good job of describing the different levels of alertness. So, looking at this, I think we all know what being alert is. Lethargy is probably a term that is misused by a lot of non-clinical people, and this chart does a good job of describing it. I think of lethargy as drowsiness to a degree. It's someone who kind of tails off, but can be easily aroused and is pretty with it once they're alert again. An obtunded patient is someone who has to be woken up by touch. Their response time is often delayed, and their answers may be inappropriate, and they will easily tail off again if they're not continually cued. Stupor is an extension of this, but instead of a simple tap or a shoulder rub, it requires repetitive, vigorous, and often painful stimuli to make the patient become alert. An example of that's the sternal rub, doing the nail bed pinch, things like that. A comatose patient is someone who does not respond to any external stimuli and is unconscious. To the right on the slide, you see the Glasgow Coma Scale, and the GCS is another example of a way to measure alertness. Hockey sticks, 111, etc. indicates a score of 3 and is the lowest score, and that essentially signifies that the patient is comatose. A score of 15 is the highest and indicates an awake and alert patient with no deficits. If your patient is not alert as advertised, consider why that is. Is it a medication relation as far as like an opiate or a benzo? Do they have an infection? Is it a neurological change? Is it something metabolic like hypoglycemia? Things like that. So don't be afraid to wake up your patients and to check on their neuro status. So the next thing that I'm looking for on my bedside neuro check is, does the patient follow commands? Do they have purposeful movement? Are they trying to swat you away if you're giving them painful stimuli, things like that? Can they do what you're asking them to do in terms of maybe raising an arm or a leg, giving you a thumbs up, things like that? Can you get them to squeeze your fingers? But yeah, the big thing is that movement purposeful? Anytime that you have something that seems off in terms of following commands, ask yourself why. It oftentimes helps to correlate things to the imaging that the patients had. If they have left-sided deficits, did they have a right-sided stroke, things like that. And it's also important to note that saying, well, that's how this patient's been all day or all night, is not an assessment finding. That's something that irritates the snot out of me. It's not okay to use as an excuse. It's important to be able to pinpoint at what time a change occurred and why that change occurred, and be sure to relay that to the provider. So after looking at the patient and determining if they are alert and following commands, what I typically do next is look at their pupils. I like to see what size they are, if they're round, equal, and reactive to light. Do they react at the same rate? Things like that. Deviations from normal can indicate a variety of guarded prognoses, such as head trauma if pupils are unequal, aneurysm rupture if pupils are blown, opiate overdose if pupils are pinpoint, things like that. And I also use this time while I'm looking at their eyes to see if there's any nystagmus, strabismus, and things like that. So I also think it's important to evaluate a patient's strength, and this slide is pretty self-explanatory. This is probably more provider level in terms of grading strength on the 0 to 5 scale, but I think it's important to be able to note from a nursing perspective, what all that's going to entail. So a score of 5 for a patient's strength is going to indicate that they have normal power in their muscles. A 4 plus is going to indicate that they have submaximal movement against resistance, meaning they do have that effort against it, it's just not perfect. A 4 is going to be moderate movement against resistance, the 4 minus being slight movement against resistance. A 3 is going to be movement against gravity, but not against resistance. So they are able to lift that extremity, but they cannot resist. A 2 in terms of strength is going to be movement with gravity eliminated. A 1 is going to be like a muscle contraction or that flicker of movement, and 0 would indicate flaccidity or no movement whatsoever in those muscles. So I next like to check sensation of the patient. So a proper sensory exam, if you're doing it by the book, typically provider level, it's going to require using a sharp and dull stimuli such as a broken tongue depressor and a cotton swab, and having the patient close their eyes and then try to get them to localize where they're being touched and then identify if it's sharp, dull, all that. I know that's pretty unrealistic to do at the bedside, especially to do that briefly, so I typically improvise and do kind of a pseudo sensory exam at the bedside. So what I do is I typically test like proximal and distal sensation to the extremities, all 4 of them, as well as the face. I'll have the patient close their eyes and then touch the patient in 2 identical spots on either side, such as, the bilateral calves. And then I try to ask them where I'm touching them and if that sensation that they're feeling is same or different on one side or the other. It's important to be sure that you're not asking it, do these feel the same, do these feel the same, do these feel the same, things like that, because that could skew their answer somewhat. You want to make sure, do they feel same or different, so it's not a loaded kind of question. If there are any abnormals, I then, of course, investigate further. One way of doing that is something called cortical sensory function. There's several different varieties of this. So one is having the patient close their eye and then placing something that they would recognize in their hand, such as like a quarter or a key or a pen in the palm of their hand. And that's called stereognosis. Another form of this, of the cortical sensory function, is having the patient close their eyes and then drawing maybe a letter or a number with your finger on the palm of their hand with their eyes are closed, and that's called graphesthesia. And then a final way of doing this is called two-point discrimination, and that's essentially where you have the patient close their eyes, and then you use maybe two pens or something, and then you're having them distinguish between 1 and 2 simultaneously closely placed pinpricks on their fingers, so just kind of slightly tapping them with two of the pins and then one of the pen and having them differentiate, and that can be telling because it's oftentimes hard to do that if their sensation is impaired. I also like to check distal pulses as part of the neuro check. Pulses are graded on a 0 to 4 plus scale, with 0 being absent and 4 plus being bounding. 2 plus is considered normal. It's imperative that we're checking distal blood flow and circulation, and I typically do this by checking radial pulses and then something in the foot, whether that be the dorsalis pedis or the posterior tibialis pulses. If they're diminished or absent, it's definitely pertinent and the provider should be notified. Don't be afraid to get the Doppler out and to find the pulses that way if they're tough to find by palpation, or you're unable to find them by palpation. And it's also a good idea, if they are hard to find, get a Sharpie out and mark them. So that way you know where they're at, the subsequent shift knows where they're at, and that way they're easy to track that way when they're hard to find. Alright, so in addition to the normal bedside neuro check that you're going to do on everybody, there's going to be some additional considerations for stroke patients that need to be utilized. The first of these is going to be looking for if the patient has a gaze preference or a disconjugate gaze, if they're unable to cross the midline in terms of their eye movement. And then I would look at their face and note if there's any facial droop or facial asymmetry. I like to listen to see if their speech is fluent and appropriate, if they're able to talk. You need to note if there's any dysarthria, as well as any expressive or receptive aphasia. And while you're typically going to do a full NIH on these patients at some point in your shift, typically early on, I don't typically do one at shift change at the bedside unless their condition warrants it, or it's applicable if you're seeing a major discrepancy from what you're seeing acutely versus the reported score from the prior shift. So if somebody tells me a patient's NIH is a 5, but I walk in the room and it appears to be a 12, just kind of offhand, or no, it's going to be like double digits, then it's definitely a pertinent time to go ahead and do an NIH just so you have something to compare to. Alright, much like there are for stroke patients, there's also going to be some special considerations for surgery patients, and here we've got us ACDF, and then a lumbar laminectomy. Alright, so there are also the special considerations for the surgical patients. I like to check to see if the patient has any saddle anesthesia or anesthesia of the groin, as well as ask if they've had any new onset incontinence. I just say, hey, you pooping and peeing okay, or you pooping and peeing on yourself. But anyway, that can be pertinent in the event that the patient has an epidural hematoma, has cord compression, or cauda equina syndrome in a preoperative patient. I also like to note if the patient's functional or mobility status has changed. I like to ask around, have you been walking around? Are you having any trouble getting around? If a patient was previously getting up ad lib but are suddenly having new onset weakness that is preventing them from moving around as well as they were prior, then that's an acute change that needs to be relayed to the provider. Like to know if there's any weakness there that's new or different. And also, if the patient's an ACDF, measure their neck, get a tape measure out, and do it. Do it about 4 times per shift and get some tangible data, because there's no other way to get that to the neurosurgical provider and give them an estimate about what is happening with the patient's neck and if there's any swelling that could potentially compromise the airway. So it's imperative that you're measuring the neck on ACDFs. Take note that the trach kit lives in NCCU by the supply room back there. Remember where it's at in the event that we need to use it on a compromised airway. Alright, well, here is just a nice little snapshot showing what a hematoma can do following an ACDF, and showing that that hematoma can compromise the airway with that swelling, and it just does a good job of demonstrating what that looks like. And here is a couple pictures demonstrating what an epidural hematoma looks like. You can see that hematoma is causing swelling and subsequent cord compression in that far right picture. And of course, those will provide tangible neurological changes in a patient that's pertinent to pick up on. Alright, so the big take-home points, if you're not listening to any of this presentation except for this slide, the big takeaway is get off your butt at shift change and go do your bedside neuro check. It is imperative that we get this done because it allows you to get a baseline assessment as far as neurological function on your patient. We all know how it goes. You're getting a report, then an IV beeps, you go to silence it, then somebody's got to pee, and then somebody needs PRN pain meds, and then you blink and it's been 3 hours and you still haven't made it to go see your patient. So doing this bedside neuro check at shift change prevents that from happening. You've got somebody there that can help cover, so you can go in there, do what you need to do, and get that baseline assessment done. It is also extremely important that the off-going shift and the oncoming shift are in agreement with a patient's neurological function, that they're both saying the same things and can agree that at that given point that patient is doing X. Certain patient types, such as strokes and surgeries or post-op patients, are going to need additional assessments to establish that baseline neurofunction, in addition to the stuff that I talked about previously. So as far as them being awake, alert, following commands, their strength, sensation, all that, strokes are going to need certain stuff, and surgeries are going to need certain stuff. And then finally, while these few assessment techniques are crucial to practice on every neurological patient, and note that's neurological patient, not every patient, don't be doing this on a sickle cell, know that this is not a rigid or static list. If you find something that seems off or seems abnormal, investigate it further. Do what you need to do so that it feels like you and your partner nurse have an equal understanding and are in agreement on what a patient's neurological function is. Alright, so that kind of wraps it up and kind of gives a good summary of what we're looking to do. If you have any questions, comments, concerns, feedback, any of that stuff, please don't hesitate to reach out to Bob or I. And then otherwise, you can expect us to kind of be peeking in on some bedside neuro checks to make sure that we're doing this consistently with all of our neuro patients, and everything's rocking and rolling. So thanks for your time, guys. I appreciate it.